Hello, everybody. This is Dr. Hamid Elmir. I am the host of podcast with Dr. E. At this podcast, I sit with the world's experts in health, education, and community development to talk about current health challenges and ask them to share their experiences, knowledge, and thoughts with all nations across the world, especially the developing countries, so that we can learn from experts across the globe. Without further ado, let me introduce you my guest today. On the show today, we have a great physician with us who is an infectious disease specialist and has worked at the forefront of infectious diseases from HIV/AIDS prevention and treatment to novel coronavirus in New York City. As a physician who has dealt with infectious disease myself, I am well aware how tight Dr. DeHaan's schedule is. Yet he kindly spared some time to talk with us about his experience and share his wisdom and knowledge with us all today. Soon we will learn more about his work in coronavirus, what will be his advice as we are close to the flu season. Ladies and gentlemen, let's welcome Dr. Elliot DeHaan. Thank you for being with us, Dr. DeHaan.
Thank you. Hi, Dr. Hamid. Thank you so much for having me on the show. I'm excited to be here.
It's a pleasure to have you on the show. Dr. Elliot DeHaan has worked as a clinician, clinical educator, and administrator of HIV, HCV, and HIV prevention programs at academic medical centers and community health centers in New York City for the past 10 years. He is currently an assistant professor of clinical medicine in the Division of Infectious Diseases at Weill Cornell, where he joined in 2017. He provides comprehensive primary care to HIV-infected persons as well as chemoprophylaxis for HIV prevention at the Center for Special Studies. He also serves as a clinical consultant for the Weill Cornell chapter of AIDS Education Training Center, providing didactic teaching on HIV, ID or infectious diseases topics, and teleconferencing support to community health centers of New York City. He has been a member of New York State Department of Health AIDS Institute Medical Care Criteria Committee since 2015. Prior to his time at Cornell, he was an attending physician at Montefiore Medical Center, Community Healthcare Network, medical director of HIV services, and SUNY Downtown Medical Center. Dr. DeHaan, as you know, I'm trying to bring people to people in an authentic, genuine, and non-political professional way through this show, and I am sure this is not the only show doing this. With that said, let me ask you the very first question. Like always, I start my first question at a more of a personal question. Why you do what you do?
Sure. So I became interested in infectious diseases shortly after finishing college. I graduated college in the Boston area in 1999, and I decided to stay in the area and work at an immunology lab. And one of the things I loved and grew to love in this immunology lab is the interaction between a microbe and a host. And infectious diseases as a field, we call it ID for short. ID is one of the few medical fields where you have this two organisms kind of battling it out, so to speak. Whether that other organism is a bacteria or a virus or a fungus or another microbe, and then you have the host and the host immune system. I found this interaction very fascinating. And specifically, I became interested in human immunodeficiency virus, HIV, and its effects on the immune system. So I worked 2 years in that lab, and after completing 4 years of medical school in my home state of New Jersey, I decided to take a more of a clinical pathway rather than a research pathway. And so I went on to do internal medicine residency. I went back to the Boston area after medical school. And then I came back to New York City in 2008 and started an infectious disease fellowship. For my fellowship, I did that training at New York University, NYU. That was the start of my career in infectious diseases. And since 2008, I have been involved in the care of many patients in New York City who have been affected by infectious diseases. In my very first year of training, I got hit with the H1N1 swine flu pandemic. That was a worldwide pandemic that affected New York as well. After that, I also became very heavily involved in the longstanding HIV epidemic of New York City. Another thing that evolved at the time of my training was hepatitis C treatment. And so I became very interested in the treatment of patients with chronic hepatitis C and using the new direct antiviral agents for hepatitis C. So I feel, like my time in New York has been spent dealing with a lot of infectious agents, infectious diseases, and now more recently, as you are aware, and why we're here today, I got involved in COVID-19 and the treatment of patients with COVID-19 disease. And we'll talk more about my experience specifically with that as we go on today. Just another point on why I found infectious disease interesting. In addition to the complexities of the microbe and host interaction, I also find that there's another level of this, what I call the psychosocial dynamic, and that includes how socioeconomic status, issues involving mental health, and also substance abuse, and also behaviors may affect outcomes in treatment and prevention of disease. So, this added layer of complexity, I think, just makes it all the more interesting to me. And it's another reason why I was drawn to the field of infectious diseases and continue to be so drawn today. Just to piggyback on that, we've heard a lot, specifically to COVID, about the difference in treatment outcomes in the media when it comes to comparing different racial groups, different ethnic groups, and different socioeconomic groups. So that's another, I think, key factor, even specific to COVID, that I think we have to do more research and learn a lot more about.
Well, thank you very much. It's very interesting that you brought up the idea how you got interested in the field of infectious disease, the studying the microorganism and the host, and how this pandemic has affected people of different ethnicities and races, not only here in the U.S. but also across the world in different measures and strengths. Like, as infectious disease has always been one of the challenges in the developing world as well, where I come from in Afghanistan. I've seen a lot of measles, which is still in Afghanistan, including polio, which is Afghanistan is one of the countries that still is suffering from polio. And on the other hand, this coronavirus luckily has not been affecting kids that much, or we haven't heard this. I would like you to also let us know, does COVID-19 affect children and adults differently?
Yeah, so I take care of adults, but I can comment on that issue, and will. Let me start my comments by talking about the treatment aspects of adults and the clinical disease in adults. One of the challenges that we've had in this epidemic is having access to evidence-based research and guidelines to help us know how to treat COVID-19 patients, both adults and children. And for your listeners who may not be familiar with what we call RCTs, or randomized controlled trials, I just want to take a step back and talk a little bit about what those are, and then tie that into treating COVID-19 now in adults and children. So for those who may not be familiar, these types of trials, RCTs, are essential because they eliminate, as best possible, biases that can be introduced into your comparison groups. So, for example, if you want to see if a particular medication works, the only way to figure that out, the only way to achieve this is to compare the medication to another standard of care in similar groups of patients. So you don't want one group to be really healthy and the other group to be really sick. You don't want too much of one comorbidity in one group, like diabetes, versus another, the other group, because that's going to influence your results. And the same can be true said about age. The same can be said, about including children versus adults, gender, male and female, and et cetera, et cetera, et cetera. And so it's vital that we have, as doctors, evidence from clinical trials that are randomized and controlled, so that we really know whether or not the intervention works or not. Now, what we're getting in this pandemic, we're getting some randomized control data, but we're getting a lot of what we call observational data. And observational data can be helpful. It's not the worst kind of data, but it isn't randomized. And what you get with observational data is an outcome that may have been influenced by the choice of who got an intervention versus who did not get it. So in retrospect, when you're analyzing observational data, you may see that one group got a drug because they were healthier or they were younger or less likely to have side effects. And we've seen that with certain medications, including hydroxychloroquine, which has made a lot of news and buzz in the media. So for any intervention, whether it be remdesivir, the antiviral agent, or hydroxychloroquine, or steroids like dexamethasone, you want to look at this in the setting of a randomized controlled trial and eliminate any of these biases so that you know whether or not this intervention works. So more recently now, we're getting some of this randomized control data, and that's exciting. And most of it's nearly all in adults. Unfortunately, we don't have a lot of data in children, as you were asking, but that may be changing soon. And I'll talk a little bit about that. Some of this information has been publicized in the media, and I know the New York Times has published a lot about this, and CNN, et cetera. Most recently, I'll talk about academic journals. There was some data released supporting, the use of remdesivir. It was published in a very well-known, prestigious journal called the New England Journal of Medicine in May of 2020. This data demonstrated an improvement in recovery time, 11 days versus 15 days, and also a difference in mortality of 7.1% versus 11.9% with remdesivir. This study made a lot of buzz, and Dr. Tony Fauci spoke about this data, and the media was very excited about this data, and rightfully so. We're happy that we have something that has an effect on this virus that was demonstrated in a randomized controlled trial, and it's a true effect. So this allowed for this evidence led for this drug to be included in certain guidelines, and we'll talk about that doctors now use to treat COVID-19. Another study was released in July. This also made the news, showing a difference in the incidence of death when patients receive dexamethasone, that is a steroid, either orally or intravenously. Particularly, this improvement was seen in patients who were on mechanical ventilators. And so in that population, in the patients who were on mechanical ventilators, they saw a difference in the incidence of death, 29 versus 41%, which is pretty dramatic. And this made the news headlines again. Guidelines evolved, and they included steroid use as well in their recommendations. So now we have like two medications that now have building evidence that's based on randomized controlled trial that have, gotten into the hands of doctors, and we can use these with guidance from guidelines and studies, particularly in adults, based on this data, and that's exciting. Lastly, I'm going to mention some what I call negative randomized controlled data that showed, less of a benefit or no benefit at all with hydroxychloroquine, in contrast to a lot of observational studies. And remember, I talked earlier about what potential biases can be introduced in observational data.
Yeah.
And so, we see a lot of people arguing about hydroxychloroquine, and a lot of people who favor its use, they point to a lot of observational data, which there is a lot of this observational data. But when you analyze the observational data, you find that the difference in many cases is accounted for by some of these other biases that have been introduced, whether it be that the patients were less sick or the patients had less cardiovascular disease or less diabetes. And we also know that these comorbidities are affecting the outcomes in and of themselves. So you have to eliminate those other factors when you're comparing these groups. So, in conclusion, I just want to say that based on this randomized controlled data, the NIH published COVID-19 clinical guidelines that are updated routinely, and doctors can access these. They should access these. You can easily Google it, COVID-19 NIH guidelines, and they are updated on a regular basis with recommendations from experts based on the randomized controlled data that we get on various interventions. Mm-hmm. So getting back to your question on children, remdesivir has been used under Gilead's compassionate use program, and there's an existing emergency use authorization EUA for remdesivir, and it has been used for in pediatric populations under that EUA. And I'm happy to say that there is some clinical data that is being acquired now on the use of remdesivir in children. And we are looking forward to seeing that data. We don't have it available right now in published form, but soon, hopefully, we will have that data. One thing I wanted to add is that there was a particular concern that came up in New York City around children, and that arose around the diagnosis of pediatric multisystem inflammatory syndrome that it has been associated with SARS-CoV-2 virus. This particular syndrome that resembles another one called Kawasaki's disease includes low blood pressure, hypotension, that is of a cardiogenic or vasogenic shock etiology. It also includes evidence of severe cardiac illness, such as myocarditis, which is inflammation of the heart muscle, pericarditis, which is inflammation of the pericardium that envelopes the heart, or valvulitis, which is inflammation of the valves. Other end organ damage, a rash, conjunctivitis, and other gastrointestinal symptoms. The New York Times and other major media news outlets wrote a lot about this particular syndrome, and these cases were required to be reported if persons under the age of 21 were expected to have it. And so there were multiple announcements made and notifications sent out to doctors throughout New York City, including infectious disease doctors like myself, to be on the lookout for this. So that was one aspect of COVID-19 disease that was a little bit different in the pediatric population, although I suspect in the end we may see that it's a spectrum of disease that maybe looks a little bit different in children, and we are seeing other inflammatory syndromes in patients, which I'll talk about a little bit later in the talk, specifically in adults, and something called cytokine release syndrome that is associated with COVID-19 disease.
You just laid it out really well, and thank you again for sharing your knowledge on this. It really is important. You brought up the idea of, the facts and the reports about remdesivir as well as the dexamethasone. I remember when the dexamethasone news was out, and they used it for the critical patients at the hospitals, especially in the developing world. People were just waiting for treatment, and where I come from in Afghanistan, people were, I think that at that point when it was announced, that was the peak of the coronavirus back there, and a lot of people were waiting for a treatment, and I kept receiving texts and emails and calls that, so am I going to use this? Like, a lot of patients who were like, they were just at home and not critical conditions.
Right.
And so many people were a little confused about it too. If that was a treatment for, a home treatment for coronavirus, which I try to make it clear that that's not for everybody, and it's only being used at the hospital for critical patients. And I'm glad you brought up that also here today. And with the children, of course, the Kawasaki-like disease, which was a little concern in the U.S., but also in Europe, I heard about it, and even in the developing world. And I appreciate if you know any pediatricians of any colleagues, friends, and then we can have him on the show to talk about specifically for kids. And I really appreciate your comments on this. I know you're not treating the kids, and thank you so much. And that was really informative about the especially on the adult sites. Pandemic is really, it's hard now to really expect when is it going to end, or where are we. Infection rate is actually slow, and as well as the number of hospitalizations and the death, everything is lower, especially here in the Northeast, which is really good news. And I'm pretty sure you have experienced it in treating patients. But still, most people are worried that the COVID may become worse during the flu season and close to the flu season. What do you think?
So my most important piece of advice is please get your flu shot. Please. Flu shots are effective at preventing influenza disease, or at the very least, they are able to improve, decrease the severity of disease, particularly in vulnerable populations. Unless your doctor has told you that you should not get it because you have an allergy or some other contraindication to getting a flu shot, you should get your flu shot this season. If you're not sure, ask your physician if it's safe to get. We can only hypothesize what may happen in the U.S. come seasonal flu season. One thing I want to stress to your viewers, let's just start off with basics. These viruses are not the same, okay? Yeah. Influenza is made of 8 single-stranded RNA segments, okay? SARS-CoV-2, which is the virus that causes COVID-19, is a single-stranded, non-segmented viral RNA. Mm-hmm. We know, based on data, that co-infection is possible, definitely. We have seen co-infection of SARS-CoV-2 with other viruses such as RSV. Okay, we have seen it co-infections with influenza. And there was, in the reports from the initial outbreak of COVID-19 in Wuhan, China, they definitely documented co-infection there. Now, what's different for influenza, in addition, we have a vaccine already for influenza. It changes with the year. We also, though, have FDA-approved antiviral agents. That's something that we do not have for COVID-19. Not even remdesivir yet. And remdesivir has an EUA, but it doesn't have an official FDA approval. We have two, more than two, but two that are very commonly used in the United States. Also, Tamiflu, also known as Tamiflu, is a brand name, and baloxavir, which was just recently approved. And we have other agents as well, in addition to those two. These being two very common ones that are used. So we have a way to prevent influenza. We have a way to treat it effectively. How that will play out with co-infection, we just don't know. We have looked at the Southern Hemisphere data as of right now. And interestingly enough, it appears when you look at the Southern Hemisphere data that the influenza rates are uncharacteristically low. So around the same time last year, they were at rates of 10% or above. Now what they're seeing is that they're below 10%. Now, a lot of experts speculate, like, why is that? Is it because of COVID-19, or is it because we're underreporting? Are people not getting tested because they're avoiding healthcare? We don't know. So I think, it's hard to really predict what's going to happen in the Northern Hemisphere come the flu season based on what's happening in the Southern Hemisphere. And I think that we're all going to have to wait and see what this year's flu season brings, but only after all of us get our flu shots.
Right. Yeah. Well, thank you again. Thank you for mentioning this. Yeah, and of course, also I would encourage everyone to take their flu shots, and that's very important. And I think people learn a lot with this coronavirus pandemic, that as far as you know hygiene and just hand washing, basic public health measures, and social distancing and all that really has helped. And I think that I'm sure it helped also to bring the number of cases of flu as well. It was down, and hopefully people will, they should abide by the public health directives as we get closer to the to the flu season. Healthcare providers' courageous, kind, selfless, and tireless actions throughout the pandemic through the media and social media. Could you share your experience as an infectious disease physician who was at the front line of this fight against coronavirus?
Yeah. So I think, I could echo all similar things that a lot of the other doctors have said. I had lots of concerns for not only my patients, but also my family and me, how this
Right.
would play out in my own home. And so I could definitely echo all of these things. I think one of the challenges I had specifically as an infectious disease consultant, that I'd like to go even more specific than just like any other doctor.
Right.
One of the challenges for me as an infectious disease doctor was being involved as a consultant in cases where we were really trying to figure out, is the problem related to direct effects of the virus, or is the problem with the patient as a result of a response of the immune system, the host immune system, going back to my microbe versus host point earlier on. Is the issue the immune response? And so lots of times we, as the infectious disease team, would be called on these cases, and we would be asked, is this cytokine release syndrome? So cytokine release syndrome associated with COVID-19 is a explosive chemokine or cytokine related phenomenon where the immune system just goes kind of berserk in the setting of a release of large amounts of cytokines in the presence of an infectious pathogen. In this case, we're talking about SARS-CoV-2 virus, COVID-19 disease. And when this happens, this scenario can be very similar to septic shock from a bacterial infection. And so you kind of have to sort out, is this due to COVID-19 disease? Is this due to another infection that may be happening? Or is this, all related to cytokine release syndrome related to COVID-19? Many patients, because of the prolonged intubation period and mechanical ventilation, will have infectious complications from that mechanical ventilation. So I think a lot of people, and maybe some of your listeners, are not aware that when you intubate someone, there are many, many potential infectious complications that occur just from the very act of bypassing your body's natural ability to fight pathogens. We were not meant to have tubes down our throat, because it bypasses, innate immunity that is established to fight pathogens in your respiratory tree. And so what we would be seeing are multiple, bacterial infections from being on vents for 2, 3, 4 weeks, complications from trachs, bronchopleural fistulas that would lead to empyemas. So these were major infectious disease complications that I would be consulted on, and we would have to address. specifically with cytokine release syndrome, this was a really challenging thing to treat because going back to my previous point, we didn't really have any randomized control data looking at interventions in this particular case. We could extrapolate from other diseases, and that's what we started doing. We started looking at cytokine release syndrome in, say, cancer or in other types of infection. Also, in two specifically that I had experience with as a consultant was tocilizumab and eculizumab, which have made a lot of press, and there has been a lot of interest. And there is now more data coming up. Our particular hospital was involved in a trial of one of these medications, and we were able to get data from that clinical trial, and we're getting more from other clinical trials as well, and that's helping us use these medications. When do we use them early? Do we use them later? How can we rule out, another infection, a bacterial infection, prior to using these medications? These are the things that we are learning as we get more information from clinical trials. But this was one really I think specific to infectious diseases that we had to deal with. Another thing that I dealt with a lot, and again, I'd say this is more specific to ID per se, is requests from families, patients, and family members regarding specific interventions that may have some little bit of news about at the time. Ivermectin, for example, convalescent plasma, other interventions that we're still learning about, that are experimental, that we don't have a lot of information about. Even remdesivir in the beginning, we didn't have a lot of information, and our center eventually went into a mode where only in the setting of a clinical trial could you get access to the drug. But that in and of itself, when you have clinical trials, they have rigorous criteria that you have to meet. For example, the patient can't be intubated more than a certain number of days, et cetera. And so if a patient doesn't meet that criteria, then they can't get entered into that clinical trial to study that intervention. So we had to deal with situations like this all the time. And it's very soul crushing when you see that a patient either cannot get the intervention because they don't qualify for it because of a clinical trial design, or or we're not able to use a particular intervention that the family wants because there's not enough evidence behind it. These are things that really got stressful and soul crushing. It was very challenging to deal with, and I know there are many doctors who had similar situations like this all over the world. And I think for your listeners, that's something that if they're not aware of, this is something either to expect or that will need to be addressed.
Absolutely, and thank you so much for sharing that. It's been a really challenging time for a lot of physicians across the world, and you as an infectious disease consultant, you mentioned about the cytokine, release syndrome, or the cytokine storm, which was really one of the challenging issues for physicians in every country. And a lot of physicians who were, some of the physicians back in Afghanistan who were in the front line and were treating COVID patients, they contracted the virus, and they were in critical conditions. And we were continuously, talking about different aspects of coronavirus as well, from prevention to treatment. And there were, physicians from across the world. And luckily that there were some of these telemedicine and Zoom conference calls and stuff like that the physicians from New York and across the United States were sharing their thoughts and experiences with physicians back in Afghanistan. I really appreciate your comments on this, as well as you shared about how you experienced it back in New York City like a month ago or so. And I'm sure it was really tough days, not only for for infectious disease specialists like yourself, but also for other physicians who are treating patients. That brings me to the last question that we're almost getting close to the end of this podcast, and I would like you to also share your thoughts. This is a question that I ask a lot of my guests, and for some guests, it's really challenging because they come from the developed world or Western countries, and it's hard to compare the health settings here in the developing world. But since you are an infectious disease specialist, and infectious disease being one of the major healthcare challenges in the developing countries, especially in Afghanistan. What do you think for Afghanistan and especially for the infectious disease specialists in terms of controlling coronavirus and infectious diseases in general?
My strong recommendation to other parts of the world, including Afghanistan, is, testing, tracing, and containment, and do it early. Unfortunately, in New York City, the pandemic exploded in a manner that did not allow for us to achieve these goals. Instead, we had to quickly adapt and use a mitigation strategy using lockdowns and social distancing measures. I am happy to say now that testing is much more available, widespread in New York City, and there is a major campaign by the New York City Department of Health to encourage more testing, both in symptomatic individuals as well as asymptomatic. Once you have testing down, once you have that foundation, which you need that foundation, then you can move on to contact tracing and containment, right. and isolate individuals who are positive and do it appropriately so that you can contain the spread of this virus. Otherwise, if you aren't able to contain it early, you will not contain it. And that's been shown all over the world. And, I don't need to mention particular places of the world, but there are definitely places in the world that have done much better than other places. And I think this virus took New York by surprise. We were all shocked as to how widespread it was so quickly, and we just did not realize it. There were well publicized cases early on, but I believe that was just the tip of the iceberg manifesting itself. There were many other cases in the community that were happening at the same time, and they weren't picked up. And you don't want that to happen in your country, in your part of the world. So wherever you are listening, if you are at the beginning of an outbreak, the key recommendations of testing and tracing and containment need to be followed absolutely. I'm happy to say that our recent data is much more promising in New York City. We have been plateauing in terms of new cases. The most recent numbers that I have received in my field, we have around, in New York City, 222,000 confirmed cases, roughly, and around 19,000 confirmed, 19,000 deaths. And specifically, our hospital numbers, in terms of new cases being admitted, we have been running around 1 to 2 cases in a 24-hour period, which is a huge improvement compared to earlier in March, April, and parts of May, when we were seeing much higher numbers. So there is hope that with mitigation strategies that we use, lockdowns and social distancing, you can have a huge impact on the curve and flatten the curve, as the saying has been used in our field and in the media. And that would be my advice to the rest of the world and your listeners.
Well, thank you so much for those are really important points, especially when it comes to the developing world. Those three measures that you mentioned is really important, and I'm really happy that at this time that we are speaking right now, as you mentioned, New York City has coronavirus, and it's to the lowest numbers. And I used to come to New York like almost every second week and seeing my friends, having meetings, and even sometimes for just having trying different foods in New York area. And it's been like 6 months that I was going to work, but I really wasn't going. This, of course, the social life was kind of really restricted, and we couldn't go and socialize or eat in New York City. But it was a week ago or so, I was in New York City. That was a totally different experience for me, like as if like that was my first time, and seeing it was a new world. And I'm really glad that people were enjoying like outdoor seatings, and and I really thank you and all the frontliners and physicians across the world, especially here in New York, New Jersey area, that you've been working tirelessly day and night. As I mentioned earlier before you, I had also Dr. Tyler Evans from New York, and at that point it was a little tougher time, and we were hoping that we would get to phase 4. And I remember I questioned him if that was like to happen. And as I said that time, and I repeat that New York is a city that never sleeps, and it never slept even during the pandemic. Although people were quarantining and staying at home, but people like yourself and physicians in the front lines and other people who were providing food and supplies were always available there, and they never slept. And thank you again for your time. It was a pleasure to have you on the show, and I wish you all the best with your career, your work.
Dr. Hamid, thank you for having me on the show.
It was a pleasure. And dear audience, thank you for listening, and stay tuned for more amazing guests to come on the show. Have a great day.